can show you the fact that you are more impulsive if you have these gene variants. You have a less sensitivity to the sedative effect of alcohol, and you have more dopamine firing and more reward induced by alcohol. Not having this subunit clearly is putting you in a protective condition respect to alcoholism. Having this subunit variant is putting you in a risk condition. Again, this is happening also for other candidate genes, such as the genes related to serotonin neurons or dopamine neurons, dopamine transporter, serotonin transporter genes that are making the system of serotonin dysfunction and more easy to develop impulsiveness and aggressiveness. For example, it has been evidenced clearly that a large part of the people smoking cannabis has been influenced by their genetic condition. So I told you that epigenetic was counting a lot in terms of influencing the effects of drugs on the brain and establishing this kind of crystallized system. Now I tell you that epigenetic changes are counting a lot also in influencing the vulnerability happening before drugs that is bringing people to remain trapped in the system of compulsive conditioned behavior. You see, for example, this is an evidence about prenatal stress. During pregnancy, if you have prenatal stress, you have at risk of disrupted dopaminergic system and making you a candidate for substance use disorder. But in reality, what is making you at risk for this dopaminergic system alteration is because of alteration in gene expressions. So epigenetic stress during pregnancy is going to modify our vulnerability because of epigenetic changes and changes in gene expression modulating our temperament. There is an impressive article that has been found, has been written recently, also in relationship to the opioid crisis and to the opioid epidemic and the addiction epidemic in the world, in the globalized world, that someone say that is behind this kind of condition, there is a situation of suffering related to an epidemic of attachment disorder, parent-child attachment disorder, that is going to undermine the brain of our children and reduce their resilience, again through epigenetic changes. You can see that genes can influence also the temperament of the children and going to make them less easy for the mother to develop a good attachment. For example, irritable babies are developing an anxious attachment, and avoidant children reduce maternal sensitivity. And this characteristic of the children could be both for genetics and also epigenetic changes before the pregnancy. The long list of adverse childhood experiences affecting our children, this is an appeal to protect the children if you don't want to see drugs around the world, affect the brain through epigenetic changes. And again, Professor Nemeroff, the expert of prevention in the United States, said that the paradise lost, the infancy under maltreatment, is really a disaster for the brain of the children, and the changes making them vulnerable for drugs are mediated through, again, through epigenetic changes. I'm finishing, I'm sorry. I am here the chairperson pushing me terribly. It's a very stressful condition, then my cortisol will go up and my glucocorticoid receptors also go down. I tell you that there is people who are very lucky. In this case, you have a trauma, you don't develop epigenetic changes, and you say, I have had the same trauma of my brother, I did not develop any post-traumatic stress disorder, and they did not develop any addiction. But in reality, it was because I was a good boy, he was a bad boy, a bad girl. It is not true. You are lucky, your brother or sister were not so lucky, because in reality, your brother or sister have a gene that was protecting, you have a gene that was protecting you from epigenetic changes, so the genes can interfere with epigenetic changes and protecting you from this stable rearrangement of your DNA expression. On the other side, the epigenetic changes can affect the genes. You can see here the short genotype that is considered a gene at risk, having a low level of unresolved loss and trauma, because it is such as turned off, the problematic gene, simply because there are in the group where we have a high level of methylation making epigenetic changes. On the contrary, the risk, the protective gene variant, that is the long, you see they have a high level of unresolved loss and trauma in dark gray because of the methylation in that group. So in reality, there is a continual interaction between epigenetic and genetics. This is becoming very pragmatic, because if you have, you understand that we are in front of a system that is very plastic, very changeable. We cannot say I have had the bad luck of being born with certain genes and certain epigenetic changes. In reality, the educational activities, any work related to high-quality reading environment can change completely the things, the trajectory of the children and the adult. Also particularly those who are at genetic risk. So in reality, this can change the trajectory in spite of what you received from your inherited genes and epigenetic changes because of the environmental problematic situation. Again, for this father interest in his child is changing the risk related to the transporter serotonin gene, problematic gene, short. Again, in our studies, we demonstrated the same. I ran out of time. Look that the brain is modified by maternal support, for example, and maternal depression, not only in reality in relation to the function, but also in relation to the morphology. You have a big hippocampus in school-age children when you have high maternal support and low maternal depression. The dimension of the certain portion of the brain are changing. I want to conclude also not to forget that the entire system of vulnerability is very much related to the experience of mental illness during the life of people with substance use disorder, and vice versa, the substance use disorder among those who are suffering for mental illness. And we imagine unexplored and uncontrollable genetic and epigenetic changes that are characterizing these individuals with co-occurring mental health and substance use disorder. Finally, let me remind what we can do. We can do at the global level in terms of policy. We have clearly established this, defined this in our international standard of treatment, of prevention that we published with the World Health Organization. Children's social protection, improving parental skills, and school connectedness could be really the key elements for changing the trajectory of children, particularly the most vulnerable. We have to make all our efforts to change the reality for so vulnerable people, so poor people who are really not lucky and not guilty, not to be punished, but to receive social cohesion and social support. Thank you for your attention.
Thank you very much, Gilberto. And if you have any questions, please just note them down and we can come back to Gilberto at the end. But I'd like to move on to our second presenter and welcome Professor Emma Jane Rose. She is Assistant Research Professor and Associate Director for the Program for Translational Research on Adversity and Neurodevelopment. And she'll be presenting on environmental influences on neurodevelopmental trajectories underlying risk, relevance for substance use. Thank you very much.
Hi, can everybody hear me? Lean in a bit. Now that everybody knows who I am, I'm going to take my name down so I can see the screen. First of all, thank you for having me. Thank you for being here. Same problem. There we go. I'm going to do the acknowledgements up front in case I don't have time at the end. So I just want to thank basically all the people who have made the work that I'm going to talk about today possible. Dr. Diana Fishbein, who's actually our director in our program. I also just want to highlight Dr. Georgia Peachy, who is a postdoctoral fellow with us, who's responsible for a lot of the data analysis that I'll talk about. And the team who work on the Centre for Healthy Children. I'm going to talk about some neurobiological impacts of childhood maltreatment, their relevance for substance use, and how we might leverage that for improved prevention. And so all these folks on this side of the screen, Dr. Jenny Knoll, Hannah Schreier, Adan Shalev, Chad Schenk, and Christine Heim are really the team who make that work possible. And I also I don't have on this slide, but to thank the United States National Institutes of Health for funding most of the work that I'll talk about today. So I'm going to talk to you about. I'm going to talk about environmental risk for substance use. I'm going to outline a working model that we have for trying to understand how adversity, trauma, stressful environments in interaction with genetics give rise to specific intermediate phenotypes at the level of brain that change liability for young people for substance use, how we might then use that to understand what potential pathways either to or away from substance use might be, and then how we can use that information, again, trying to understand what these neurobiomarkers are of risk and potentially resilience and resistance in young people, and how we might use that to better tailor and target our prevention strategies. And I'm going to talk about a couple of different prospective longitudinal projects that we've done, again, trying to delineate some of these neurobiomarkers of risk in young people who've experienced trauma and other types of adversity. And then again, I'm going to outline a couple of very recent projects that we're actually doing, again, kind of trying to look at neurobiological mediators and moderators of prevention strategies for young people. And I'll hopefully get through it all. Maybe I'll just talk. I've had some coffee, so I'll try and talk quickly. Okay. So what's the model? So this is our, we call it our cumulative developmental context model, because we had to call it something. But really what we were trying to do with this was, again, to try and outline a simple, understandable account of how we think things come together, various contextual factors, genetic factors, to give rise to risk in young people. And so we kind of conceptualized our genetic risk variants as switches. So things that are kind of binary in their nature, they're either on or off, you either carry the risk variant or you don't. Our environmental factors we refer to as gauges or dials. And really what we thought of here was there's both those that confer some sort of negative impact, usually related to adversity. So we have things like discrimination, deprivation. As I said, I'm going to speak about maltreatment and SES/poverty effects in a minute. Witnessing violence, family dysfunction, family histories of drug or alcohol abuse, which is also a tricky one in and of itself because it's not a purely environmental factor. And the idea is that you can have some number of genetic risk variants that are on or off for substance use. You can have these contextual adversity factors that can be ramped up or down. And also that you would likely have some sort of, or hopefully, some sort of resiliency gauges, right? So things that confer some sort of positive impact on brain development that are likely to help reduce the impact potentially of some of these genetic factors or these other adversities that you might experience in your life. So again, things like access to adequate housing, quality healthcare, positive attachments with primary caregivers, living in structured, nurturing environments, those kind of things. And then again, as Dr. Gerra just talked about, we also account somewhat in the model for how these two things may come together, your genetic risk plus this balance of either adversity or resiliency type factors to give rise to specific epigenetic modifications, and that accumulatively, there we go, that's why it's called the cumulative, this combination of factors will give rise to some sort of intermediate or endophenotypes at the level of brain structure and brain function that will give you some sort of cognitive, affective, behavioral profile. So again, things like behavioral impulsivity, emotional regulation, cognitive control, reward sensitivity, all of these things that will then put you somewhere on this liability continuum where there's perhaps a threshold at which you can pass that will make you at high risk for substance use. And really what we were trying to do here was step away from this kind of binary notion of individuals as being at risk or not, and really trying to get at this dynamic interaction that can vary over time for young people, right? Like nobody's life is static. Again, some of the genetic factors that we bring to the table likely are, but especially from a prevention perspective, what we're really keen on is this idea that we can ramp up some of these good things. We can target some of these neurobiomarkers that are related to resiliency or resistance to substance use, to escalation of use, to the transition to dependence for young people. And this is actually, I must have accidentally hit the button, but this is, we then thought about what these pathways might actually look like. And again, we typically think about individuals as being at risk or being resilient. And when we sat down to really try and tease this apart, and again, really what we were trying to look for was potential prevention intervention targets. And so we were trying to think about what do the trajectories really look like in real life for young people. And yes, there are some young people who experience adversity, who things happen in their life, and again, they likely bring some genetic load for risk to the table, for whom we see these changes in brain early, we see early initiation, early escalation, and a progression to substance use. We also think that there are a number of individuals who perhaps look like they're not on a maladaptive trajectory, but at some point, and this is this, and I got, I don't know, can I do that? Oh no, I'm just going to hit buttons and things are going to come up. But yeah, so this kind of upper red line, we conceptualize this as delayed risk. So those individuals for whom something changes further on down the timeline. So they don't look like they're initially at risk. They don't have, again, any of these kind of typical neurobiomarkers, behavioral markers of substance use risk, but then something happens that pushes them over the threshold from kind of the likelihood of having adaptive outcomes to having maladaptive outcomes. And then from a kind of positive perspective, we also, again, we typically think about resilience, or it's most commonly talked about as a kind of a lack of adverse or maladaptive response despite adversity or trauma or high levels of stress. And in reality, again, when we look at, and I'll talk a little bit about this when we talk about some of the childhood maltreatment work that we've been doing, but again, we do often see changes in the level of brain in response to trauma and adversity in young people that look like they might portend maladaptive outcomes, but then in the longer term, we actually see these kids kind of come back. And what we're interested in is, again, I think that's how I more typically think about resilience. And again, I think from a prevention perspective, there's potential there that what changes in the environment, what changes contextually for these kids that makes them able to rebound despite these initial changes in neurobiology that would more commonly predict maladaptive outcomes. So again, early substance use initiation, escalation, and transitioning to dependence. And we characterize in our model resistant kids as those who just fail to show any sort of significant maladaptive response. And then we took all of this, and we took, this is actually the same model that was just presented, but this, the circles, if you can read them, is our kind of conceptualization of this kind of cycle of addiction, so what we see in dependent individuals. And so what we did is we took some of that work, so again, these stages of preoccupation and anticipation, binging and intoxication, withdrawal, negative affect, and then kind of mapped that to key areas in the brain where we think these stages are likely reflected and where we may be likely to, again, to see these kind of critical biomarkers of risk and potentially resistance or resilience in young people, and then that could then potentially be targeted with preventive interventions. And so that's largely what we do in our program. But I'm actually going to talk about some work as well. So, and what kind of following this all through, what this requires, and again, this is what I'm going to talk about, is a lot of prospective longitudinal work looking at individuals who experience trauma and adversity, looking at changes in the brain, and trying to identify again what these potential markers might be. So I'm going to talk about, I'm not going to do this. Where are we going? Oh. Go back. I had it too many times. Okay, so I'm going to talk about two different studies, and again, both of them just highlighting some kind of very specific environmental aspects that we've looked at of risk and resilience for young people. The first one is our adolescent development study, which we did, Dr. Fishbein and I did in collaboration with John Meter at Georgetown University. And this is really, I'll give you the skinny on it. So in this study, what we did was we recruited 135-ish drug and alcohol naive 11 to 13-year-olds from the Washington, D.C. metro area. We did a whole host of things with them, but primarily we focused on functional and structural brain imaging, MRI, at 0, 18, and 36 months. And so what we were interested in really was what are the neurobiological precursors of substance use, initiation and escalation in these young people, and then what are the consequences. And we then we looked at a whole host of genetic, environmental, and psychosocial indices in these young people. Again, their parents did a large number of things, but I wanted to really highlight one of the kind of protective mechanisms that we were interested in this study. So we, again, a lot of what we were interested in was risk and characterizing risk at the level of brain structure and function. But some literature led us to consider that for some of these individuals, one of the things that may potentially be protective is the level of responsibility. So the level of kind of structured, responsible type actions that these young people are engaged in. The idea being that being engaged in responsible behaviors helps to strengthen cognitive control, top-down emotional regulation, given what we know about how important those functions are for substance use development in young people and in dependent individuals. The idea was that this may be protective. So again, the more responsible these young people were, as rated both by themselves and their parents, because I'm not saying we didn't trust teenagers to tell us how responsible they were, but we got double ratings. But again, our idea was that, again, this level of responsibility and social expectations within the home may actually have some sort of protective effect for those individuals who would otherwise be at increased risk. So for this study, we actually, I failed to mention this, but we targeted our recruitment to make sure that we had a sufficient number of high-risk individuals. And those individuals were characterized as being high-risk, both on individual characteristics, so again, behavioral disinhibition, those kinds of things, but also on family contextual factors and environmental contextual factors. So we had these kids who would be at high risk, but what we were trying to see here was, is this, if they're engaged in kind of responsible behaviors, that there's these kind of high social expectations, this kind of, do we see a maturing of the brain, of these higher order cognitive functions, that's somewhat protective for these young people? And I'll just put this up, so, yeah, okay. And again, we thought that higher levels of responsibility may be associated with increased cortical thickness in regions of the brain that we know are related to executive functions such as problem solving and these self-regulatory behaviors. So things like the superior orbital and middle frontal gyruses, precuneus, anterior cingulate. But of course, with this population and with most of the studies that we do, I used to keep hitting, but I don't know how many times I'm hitting buttons, things just appear. But yeah, so we were interested in, again, these kids large came from in and around the DC area. We had a lot of kids who comparatively low SES. Washington DC has a higher than average income. But what we were interested in was what the potential relationship of socioeconomic status to some of these outcomes may be. And this is from someone else's paper, but this kind of quite, and if anybody's interested in this stuff, this is quite a nice review from Farah and Nuran a couple of years ago, but just showing the potential ways in which socioeconomic status may interact with brain structure and brain function to give rise to, again, at lower SES groupings, adverse outcomes. And so, again, these are just some potential ways of thinking about it, that we can think about SES as being a moderator of the influence of brain structure and function on adverse outcomes such as substance use. 5 minutes, I better go quick. Or as a mediator of the relationship. And this, the brain figures, is really just to highlight these are how widespread and comprehensive the influence of SES on brain structure is. So these are studies, summaries of studies in adults and in kids, and related to either SES itself, so neighborhood SES is that first brain, or kind of other kind of proxies for SES, so parental education or household income in children. So we also included SES. I'm going to run through this. And we were interested in whether socioeconomic status and related family stress might also influence this relationship between responsibility and brain development. Okay, let me get it up. So I won't talk a whole lot about it. about the specifics, but we did these hierarchical regressions looking at SES, family stress, and this level of responsibility that these kids and their parents reported on cortical thickness in these kind of key areas of the brain. We did some neurocognitive testing with them. We looked at their performance on this Stockings of Cambridge problem-solving task. And what we find is, so responsibility was, excuse me, coughing away, was slightly related to SES overall in all of our individuals. So we see this kind of, actually in this particular cohort, the higher levels of responsibility in our individuals who are below the average SES for the group. So these were all standardized scores. And we see that the level of family stress is also related to responsibility. So the higher the level of family stress that's being reported, the higher the levels of responsibility in the home. And this becomes kind of important because what we found was, again, we started to have these kind of interesting effects when we split the group into our high SES and our low SES kids. So in terms of their performance on this problem-solving task, what we found was that there was no significant relationship for the low SES kids, but for the high SES kids, their performance was positively related, to their level of responsibility. So higher levels of responsibility, these kids did the task, they made fewer errors, did it in less moves, basically. And anybody's interested in the specifics of the task, I can do that later. And in terms of brain structure, what we see, again, in the group overall, when we put all the kids together, we saw this association between level of responsibility and thickness in the precuneus and the middle frontal gyrus. And again, these are important regions from a substance use perspective, for reward and motivation, for cognitive control type functions. But again, it looked like, so what we see is the more responsible individuals are, the thinner the cortex was. And so that was obviously kind of slightly counterintuitive to what we initially thought. But what it turned out was when we, again, parsed these kids by low SES and high SES, what we found was that the low SES kids were really driving this effect because they, one, had higher levels of responsibility in the home, and they seemed to be showing this kind of negative impact of responsibility. And so overall, really what it looks like is that for the high SES kids, we have this kind of protective neurocognitive effect of the level of responsibility. In our low SES kids, we see the opposite relationship. So the more responsible they are, the more thinning we see in the cortex. And again, what we actually then have been, how we're thinking about this is that potentially the types of responsibility are different. So these kids actually may have, 2 minutes, I'm going to go fast, changes that are related to stressful types of responsibility. So they're not choosing responsible behaviors, they're having responsibility put upon them because of contextual, family, environmental factors. Okay, so I'm going to very quickly try and go, don't know where we're going. Okay, so I want to talk about this other study that we've been doing, this the child health study through the Center for Healthy Children at Penn State, where we've been looking at the impacts of childhood maltreatment on a whole host of biological embedding factors and a whole host of outcomes. From a substance use perspective, this brain figure here just shows some of the regions that we know show impacts of childhood maltreatment in terms of either increased or decreased function and the pathways that they map to. So they map against these reward, emotional regulation, executive control, and this kind of fear and threat processing type network in the brain. So this is this is just in kids who have experienced maltreatment, but it maps very closely to the regions that we see as being functionally and structurally important for substance use. So in this study, again, the aim, we're about 2 years into this initial 5-year study. Our aim is to image 1,200 8 to 13-year-old kids, 900 of whom will have confirmed histories of maltreatment in the year preceding the study and 300 controls. And we're looking at a whole host of biological embedding mechanisms and behavioral and brain health. And why this is particularly pertinent for substance use is we know that these kids are 2 times more likely to initiate substance use, kids who experience childhood maltreatment, compared to their non-maltreated peers. They're more likely to initiate substance use, they're more likely to initiate earlier, and they're more likely to escalate to problematic use. And 40 to 50% of them will show some sort of substance use problem in their lifetime. So getting in on the game early. And so for this, what we did was we looked at a number of functional networks when folks were in what we call resting state. So they're in the scanner and they're not actually asked to do anything. They're just asked to lie there, to look at a fixation point on the screen, and we just take pictures of their brain function, basically. But we honed in on these particular networks, and again, because of their functional relevance, both in dependent individuals and in the development of substance use problems. And what we find is that there's within network and between network differences in our maltreated cohort and our control individuals, and it seems to be different between different types of abuse and neglect. So we find that our kids who have experienced physical abuse and sexual abuse seem to show a kind of ramping up of this executive control network amygdala function. Okay. What I'm going to do is I need to conclude because I talked for too long. So again, one of the things that we're really trying to do with some of this work is just to leverage what we understand about these neurobiomarkers for improved prevention. And essentially what we're trying to do, here we go, is again with this idea of the brain as a mediator of effects. If we can determine what the effects are that give rise to high-risk outcomes, can we then leverage that to understand better the mechanisms of behavioral change, determine efficacy biomarkers for prevention. We want to determine what works for who and why at the level of brain and under what circumstances. And I won't talk about them now, but I was going to highlight a couple of different studies that we're doing just now with high-risk populations in Baltimore City. One of them looking at the impact of mindful yoga on neuroplastic changes related to stress reactivity and recovery. So again, these are kids who live in stressful, traumatic environments. And the other study that we have just started also in Baltimore City, I don't think the clicker likes me very much, is looking again this trauma, trauma-informed intervention called RAP Club, which is run by Tamar Mendelsohn at Johns Hopkins School of Public Health. Again, we're looking at neuroplastic changes related to stress reactivity, executive control functioning in these young people before and after they receive it compared to control. This is an initial pilot of just 30 eighth grade program recipients and 30 controls. I'm going to do some stuff. But if anybody's interested in any of this, you can ask me at the end. And thank you.
Thank you very much, and thank you for keeping to time. Okay, then I'll move quickly on to our third presenter, Professor Otto Kernberg. He's Professor of Psychiatry at Weill Cornell Medical College, and he's going to present for us on drug addiction in personality disorders, a clinical approach. Thank you.
Can you hear me well? Yes. Last row? Yeah. We have been privileged to hear two excellent presentations, and with them, two major issues that affect drug addiction and the treatment. First, the biological predisposition to drug addiction, the potential for the hijacking of the reward system by the drug, and the neurobiological structures and neurotransmitters involved. And second, the influence of environmental factors, particularly maltreatment, on the activation of predisposed children, adolescents, and adults to drug dependency and addiction by chronic maltreatment that activates the negative affective consequences and the destruction of ordinary reward systems in ordinary social and psychological life, and the increased dependency and escape from that in the addiction. So that neurobiological predisposition and environmental mistreatment are two major overwhelming factors that determine the psychology of the addict. What I would like to add to this is the intrapsychic psychological consequences of this shift and concentration of reward on the drug in contrast to ordinary psychological reward systems that are contained in social life, in work and profession, in love and sex, and in social interactions and personal creativity. These ordinary sources of our gratification and rewards in ordinary life have been shifted to the drug. And what psychodynamic theory can contribute is the analysis of what the psychological consequence, the intrapsychic consequence is of a heightened predisposition to negative affective reactions to environmental experiences coming from temperament or coming from the environment, or usually from their combination. And what happens when there is an excessive predisposition to negative affective reaction, when the fight-flight affective system and the separation panic affective systems are hyperactive for genetic predispositions or for very early traumatization, failure in or insecure attachment, physical abuse, psychological abuse, chronic witnessing abuse, and chaos in early family structure, as Dr. Rose has presented, then an intrapsychic structure develops which is typical for severe personality disorders, namely the internalization as subjective psychic experience of being the victim of what is perceived as a hostile, controlling, sadistic, and mistreating environment. The predisposition to aggression, to excessive negative reaction, predisposes to see the external world in this way and internalize an image of significant others as aggressive and hostile dominators, perpetrators, and oneself as a victim. So all negative affective dispositions get transformed into a psychological structure in which a victimized self is surrounded by a sadistic other that is torturing the person. And whenever there is a frustrating social situation, it gets automatically translated in the reactivation of this dyadic situation, which means that unconsciously one tends to be identified with victim and penetrator and perpetrator at the same time. The unconscious identification with the total dyadic relationship between victim and perpetrator persists as a dominant way of interpreting negative environment and trying to escape it. And the only escape from being a victim is to become a perpetrator oneself. And from a psychodynamic viewpoint, the finding of the road to drug gratification and eventually dependency is the psychological experience that under the effect of the reward, the enormous reward gratification provided by the drug, it identifies one's sense of power, superiority, escape from victim, and unconscious identification with the perpetrator. While at the same time, insofar as one becomes the victim of one's addiction, one is victim at the same time, and one attacks oneself as the victim while being the victor in that unconscious process. And that explains strong self-destructive tendencies that are the most important common psychological features of patients with addictions and explain the fact that in the treatment of chronic addictive behavior, severe personality disorder represent a fundamental negative factor and reduce prognosis and effectiveness of treatment. So as we know, between 40 and 60% of addicted patients become chronically addicted with cycles of what used to be called detoxification, rehabilitation, abstinence, and again, relapse with the entire cycle. So chronic relapse is increased by severe personality disorders. Now, severe personality disorders has a major psychological characteristic. Sudden shifts between such states in which the individual behaves aggressively as a sadistic, antisocial element, and at other points as a victim of social circumstances and others, oscillating between that and moments of idealizing experiences of self, of relations with others that are intense but only transitional. With severe personality disorder, one falls back into the first kind of terrible negative experience of perpetrator or victim. The treatment of the personality disorder of addicted patients permits gradually to resolve that profound identification and reinforce the positive elements that the psychological treatment of addiction usually provides. Emotional support, social support, reduction of negative symptoms by medication, and re-education that helps the patient gradually to shift his reward systems. So what I'm going to describe very briefly are the essential elements of this psychodynamic psychotherapy of patients who simultaneously are undergoing treatment of drug addiction. Does it work? Okay, this, I don't know with how the general strategy is if a psychodynamic treatment for addicted patient with severe personality disorder is carried out, it should be done independently with parallel treatment for the addiction, complete independence, freedom of the treatment of addiction, while at the same time the psychodynamic psychotherapist restricts his intervention to help the patient clarify the psychological meanings of his behaviors and interaction. And the most typical psychodynamic treatment that achieves that is transference-focused psychotherapy that attempts to study the patient's unconscious identification with victim and perpetrator, dissociated from brief idealized moments of well-being, by permitting this relation to be activated in the relation with the therapist, what is called transference, the interpretation of the transference as the activation of this relationship in which the patient tends alternatively to identify himself as perpetrator and the therapist becomes the victim, and at other times the therapist is perceived as perpetrator and the patient becomes victim, perpetrator is identified with the therapist, and that tends to invert itself again and again. Clinically, this situation is reflected in a disorganization of the self, the lack of an integrated self-concept by the patient, and lack of integration of the concept of significant others that are either seen as very good or very bad. What is called identity diffusion, confusion of self and of others, that is a basic cause for the chronic chaos of the relationship with significant others of these patients. We can evaluate these characteristics in a special modification of the mental status examination called structural interview, in which we study very carefully the patient's work and profession, interpersonal difficulties and work and profession, the patient's sexual life, both the capacity for tenderness and the impossibility of tender romantic relations and the gratification in the actual sexual behavior, the freedom of sexual behavior, and whether it's integrated with tenderness or not, and the extent to which social behavior is affected by these sharp contradictions in internal experience. Practically, please change slide. Please change slide again. Practically, we have to see patients at least once and usually twice a week in order to modify the personality structure, and the patient is required to take self-control regarding suicidal and aggressive tendencies. There is an extensive discussion of the contract, and any analysis of breaking the contract is interpreted as activation of the struggle between perpetrator and victim in the treatment situation itself. A very important problem is the development of dishonesty, as drug-addicted patients tend to deny or maintain secrecies about relapse, and we point out to the patient that the temptation for dishonest, cheating behavior and undermining the therapist will be important internal motivation. The therapist acts not as a moral authority, but with technical neutrality, pointing to the patient the danger that the patient will try to undermine the treatment, and that as an expression of that dynamic between sadistic control and victim. And the technique, change slide please, the technique involves asking the patient to express freely what comes to his mind, observing his behavior in the session and outside the session, and interpreting all the problematic interaction the patient has with other people, work or profession, sex and love, and social life as the activation of this dyadic this dyadic entity between perpetrator and victim. Please change slides. We tried, it is very important to eliminate secondary gain of illness. The fact that addicted patients with severe personality disorders may often exploit the environment, refusing to work, declaring themselves incapable of working. There is no reason why a patient with a severe personality disorder should not be working if that constitutes a way of perpetuating himself as a victim of his illness. We try to control antisocial behavior while and using third parties to observe the patient's behavior and obtain information about his external life. There are particular contracts how to deal with suicidal behavior and affect storms, specific techniques, all of which tend to concentrate the therapist's activation of negative affect states into the treatment situation where they can be interpreted and resolved. we point out to the patient, we help the patient understand, let's change slides, that what seems to him as triumphant happiness during the intoxicated states is at the same time a sense of triumph and freedom and an awareness of the self-destructive potential of it, and that pleasure with the double identification as total freedom from any suffering is an illusion that clearly is going to destroy his life. We don't try to reinforce positive behaviors, but we try to increase consistently concern over the power of self-destructiveness. And let's change slide. In this regard, the approach is in some ways in contradiction to the usual effort to help the addicted patient to obtain sources of gratification and normalization of his external life by social support, cognitive and behavioral reinforcement of adaptive behavior. In the psychodynamic treatment, we stress the temptation of destructive and self-destructive behavior. Again, not moralizing against it, but pointing to its enormous and deep motivational impact, and the fact that to some extent it is a life effort to dominate that aspect of one's motivation and permit the search for loving, positive experiences in work and profession, in love and sex, in social life to take over, so that the analysis of self-destructive behavior in those three areas become a crucial concern of the treatment. We talk very little about the actual experiences, what immediately motivated going into a relapse, but about the consistent destructions of alternative reward systems that are consequences of this chronic identification with a powerful, controlling, and self-destructive entity. And let's change slides again. And in the process, the patient acquires a sense that the therapist is honestly interested and tries to help him without false reassurance, but with an honest concern for that self-destructiveness and confidence that the patient has resources to be able to try to stay alive. And patients may react at first with resentment, envy, and depreciation of what they see as the naive therapist, eventually respect for the therapist who stays stuck with them in spite of all the negative interaction in the treatment, and that brings about its success. Thank you for your attention.
Thank you very much. And I would like now to, with no further ado, introduce our final speaker this morning, Professor Yifrah Kaminer. He's Professor of Psychiatry and Pediatrics, the University of Connecticut School of Medicine. He did ask me just to mention that he has a new book coming out called Youth Substance Abuse and Co-occurring Disorders. So now you know. And his presentation will be on youth substance use disorders with co-occurring depression, the nature of the association, and implications for treatment. Thank you very much.
Thank you. Took me about 3 days to arrive to Vienna. I didn't lose my luggage, but I lost my voice. So if anybody find my voice, please bring it to the Lost and Found. So hopefully you can understand what I'm talking about. Is this the way it goes? Yes. Probably. I didn't take my Ritalin this morning, so I need to move around, but it's okay. Anyway, it'll be fine. I've realized that I have the if you will, the honor to be the only person this week who's going to talk about co-occurring disorders, dual diagnosis. So I appreciate it, but this needs to be remedied. It's extremely important not to underestimate the importance of co-occurring disorders and dual diagnosis, and I hope in future meetings there are going to be panels specifically devoted to that. Meanwhile, I would refer you to WADD website, WAD, the World Association of Dual Diagnosis. This is an international organization that is focusing on the education, research, and treatment of dual diagnosis as compared to monodiagnosis. Okay, well, another organization, we just started the Research Society of Marijuana. You won't make it this year, but perhaps next year. Okay. This is what a typical advertisement of our research looks like when we are recruiting adolescents with substance use disorders and co-occurring depression. One of the most dangerous places for young people in the United States is college. First year of college, these youngsters leave home, have no social support, they go to college. Those who are slow to warm up to social networks don't do very well at the classroom, and they start drinking, smoking dope, and then it's down the rabbit hole, a la Alice in Wonderland, and they get depressed and suicidal, and this is where we find them. So I don't know if it's typical in other countries as well, but the loss of social support and family support affect some youngsters very seriously, and that's where you can actually find dual diagnosis. Now, to give you some ideas, in the 1990s, the late Professor Kellerman called the 1990s as the age of melancholy. Well, if you would compare what's happening right now to the 1990s, is much worse. In the 1990s, sure, thank you. In the 1990s, the rates were about 8 to 9%. Now, as you can see, the rates are much higher. I'm going to do some karaoke if you don't mind. Okay, getting back to the data, as you can see, almost 1/3 of those who have major depressive episode actually are using substances as compared to only about 13%. So definitely the co-occurring of depression is quite high. Since the United States is highly populated, about 330 million people, this translates into millions of people that need to get treatment. And it's the rule rather than the exception that whomever has substance use disorder might have at least one co-occurring disorder on axis 1, and in some cases it's even 3. So bottom line, you cannot just treat substance use disorder with a monodiagnosis. You need to address it as a dual or even triple, multiple diagnosis. Now, another important issue that I emphasize, I'm a child and adolescent psychiatrist, so it's very important to look at things from what we call developmentally informed perspective. Sub-threshold disorders count, even though they don't count in the DSM or the ICD. If you can see from this slide, the bottom line is that even if you have, for example, for depression, you need 5 symptoms to meet the criteria on the DSMs, but even if you have 4 or 3 or even 2, does it mean that you or an adolescent is not depressed? And as you can see, this has become a major problem, and it definitely needs to be addressed. And give you some idea about what's happening right now in terms of the use of marijuana. So although the numbers look kind of misleading that, the wax and wane and they are the same rate, the marijuana of today is not the marijuana of my generation when I was an adolescent. Right now, confiscated marijuana, the THC percentage by weight is in the upper teens, and if you use tinctures or kind of emulsions, concentrates, can be 60 or 80%. Our kids find a way to sniff it, to inhale it. This is like pretty much, getting a bomb in your brain, because this high concentration is totally a new drug. Now, in terms of prevalence of disorders, conduct disorders is the most common one. Depression is quite common as well, and anxiety disorder to some degree as well. It's also important to understand that based actually on a very recent publication, as you can see, even negative affectivity can predict the use of drugs. And as you can see, also suicidal ideation and suicidal attempt, meaning that one of the major issues is that substance use disorder is highly associated with increase of suicidal behavior. If in addition to that you have at least one or more co-occurring disorders, it is even higher. And unfortunately, as you know, at least in the United States, since 2006, there is a constant increase every year of about additional 1,000 people who commit suicide. And I don't have much time to talk about it because it is a very short presentation, fortunately. But only about 40% of the variance is attributed to depression. And there are some other reasons, and one of them is that we are chipping away environmentally, we're chipping away some of the protective factors. Another issue I just saw a few days ago, among the age group of 10 to 14, we start to see that girls are closing the gap, and boys' suicidal behavior and girls' suicidal behavior is going up between the age of 10 to 14. However, the rate among girls is becoming much higher. It might have a lot to do with social media and other aspects, but the times, they are changing, to cite Bob Dylan, and we really need to be on top of those phenomena because they are changing very quickly. So what do we have? We have a chicken and egg controversy. Actually, what you don't know based on this book, that the chicken and the egg stopped fighting and decided that they won't argue who came first. So there are at least 5 co-occurrence models. There's a self-medication now, which sometimes we call it cynically as your latest excuse, because scientifically self-medication concept is not highly supported research-wise. There is a disease model, which is kind of nice. On the other hand, we know that 3 out of 4 people with substance use disorder have started it at their teens. This is based on several studies done in the 80s and in the 90s. The rebound effect is important because it lays a foundation, in my opinion, to what George Koob, director of NIAAA, calls the allostatic factor theory. We'll get to it in a moment. From my perspective, the way I see it, the common factor model is most probably the most important one. Why? I've never seen an adolescent only with substance use disorder. They always have some other problems, educational, family, psychiatric, legal, and so forth. And we have these very chaotic families. And these families actually are the trunk of a variety of disinhibition and other psychiatric and psychological problems. And from this common factor model that my mentor, Ralph Dart of University of Pittsburgh, used to call the Common Liability Index, and I'll get to it in a second because there is such an instrument, the Common Liability Index, there are some branches that come out of this trunk. Now, the allostatic hypothesis is kind of interesting and to some degree could help you understand why we are having one of the many explanations, the opioid crisis, and particularly in the United States. And the idea is that there is a certain progression in substance use disorder which leads to some psychiatric problem, particularly depression and anxiety. It is not, if you will, enough to maintain, the mental suffering, if you will, and then people keep on using more and more, and sometimes they resort to other drugs, and those who resort to other drugs may end up using opioids as well. And I wrote an editorial which I called the denial of the association between cannabis use and opioid use. Is it a split brain syndrome? Because we found in a study in Connecticut, I didn't conduct a study, that based on 5,000 adolescents that who use cannabis, the rate of using painkillers increased by 4 times, and the use of heroin increased even more. So based on a study that was published last year, it's a Dutch study, a nice meta-analysis in adolescents, the odds ratio is about 2. And mental health disorders are a risk factor for substance use disorder, but we know the association works both ways. And this would suggest shared liability. There's this big European study, the Genomic Consortium one, that definitely addresses common psychiatric disorders. What is really interesting though, and I don't understand why, but food for thought, all disorders, psychiatric disorders, have been found to overlap in this study. The only one that was totally an orphan, stand aside, was PTSD. I'm not sure why, but that's interesting. Another kind of older study, but it's important, so the children of alcoholics are an increased risk of developing other disorders even if they have not started to drink yet. So we need to understand this interaction between pre and post and the vulnerability of children of alcoholics as an example. So this is kind of a summary statement about co-occurring disorders, and of course the fact that I'd like you to pay attention to the fact that it might originate from a common vulnerability, and there is a transmissible liability index. I would refer you to Ralph Tarter and his colleagues' publications. It's a very good kind of concept that makes a lot of sense. I think I've been here a couple of times. I'm feeling like deja vu all over again. Which shows you that everything is related, of course, but I'm not sure what this is doing this. I'm pressing the same button. Okay, we might be making some progress. Okay, one of the concepts that some people use, it may be internalizing disorders as some kind of a protective factor. Well, there are some studies that show that adolescents with internalized disorders are less inclined to socialize with other adolescents with depression and anxiety disorders as compared to those who have externalizing disorders. They tend to socialize with each other, have conduct disorder and so forth. Actually, they're a little bit aversive to other kids who are using drugs and manifest externalizing disorders. So maybe there is some kind of protective factor. More importantly, there's kind of a relatively good study that came from the northwest of the United States about not only what initiates dual diagnosis, dual disorder, what maintains it. And they found that if people have depression before the substance use disorder, there's a better likelihood they'll be more amenable to treatment and have a better prognosis as compared to those whose depression is secondary to this. Okay, so why we cannot further ignore substance abuse in patient mental illness? Because everything is getting worse. In terms of vulnerability, liability, engagement in treatment, response to treatment, and of course, suicidal behavior, which is a major concern. So what are the negative consequences? Elevated risk for suicide, greater treatment attrition, poor outcomes, and poor overall quality of life, including social competence, mental and physical health. Okay, this is from The Economist. It's interesting that in most of the world, suicide is going down. In the United States, it's going up. A lot of phenomena that we need to deal with. I may use a term that I use, the American psyche, and if people want to know what I mean by it, I can talk with you afterwards. But definitely there are some phenomena in the United States that are atypical to what's happening in other countries, including the rate of the opioid epidemic, the lethality, when it's like 6 in Portugal per million, in the United States it's more than 300. So there's something that's going on. However, I always cite George Bernard Shaw that said that for every complex problem, there is a simple solution, and it's always wrong. So we need to understand that everything is multifactorial. Okay, one slide about suicide. Again, some studies that show that, this is serious stuff, and we definitely in any kind of treatment, need to address it. We heard the presentation of Professor Kernberg. I'll kind of send you also to Marshall Linehan and dealing with DBT, because first of all, it's survival. We call it survival analysis. We need to make sure that the patient would survive, so we will have enough time later on to deal with them and go over the life history and other aspects that made them vulnerable to dual diagnosis. Unfortunately, as a psychiatrist, I'm always blowing my horn. The most neglected section of society are adolescents. There's a study in Pediatrics from years ago that showed that actually the morbidity and mortality rates of adolescents around the world has not changed since the 1950s. Only the reason for that had changed. As you can see, in the United States, your chances as an adolescent to get good services is only if you're in prison, which I would not recommend, because at least the system is as such that it takes care of its inmate. But we got roughly 25% population of youth, and only 1/9 of them get some funding. So this is definitely an issue that we need to address. I'm sure that if I'm going to ask anybody here from the 119 countries here, all of you would admit or find out that your adolescents are definitely getting shortchanged. And this is kind of ridiculous, because these adolescents are young addicts who become older addicts if they won't die. So we need to invest in them as soon as possible. One of the problems in the United States is the silo effect. You have CSAP and CSAT, and the prevention therapists tell me, don't tell us what to do, because you're a treatment expert, and the treatment expert and the prevention people don't tell us what to do. For me, there's no difference between prevention and treatment. It's an intervention along a chronological axis using the same principles and different dosage and different frequencies. If we could put together all these agencies all together, we could have spent, if you will, save a lot of money and have one more coherent policy. But it's probably not going to happen because of the silo effect and because of power-related issues. So these are the barriers for integrated services, and all of them can be addressed, by the way, but we need somebody to be able to do it well. Now, two really quick things, because I will have to finish very soon now. I'm going to tell you about a study we are conducting right now. Two important issues. 30 to 40% of people, adolescents with substance use disorders, if you just treat the substance use disorder, the co-occurring disorders would improve, including depression. We call them rapid responders, and that's something it's important to understand. We also need to try to understand what makes some people rapid responders versus slow responders. And we have a paper that we haven't published yet, but I'll show you. It comes from the cannabis use treatment study, which is the largest study ever conducted in the world, N equals 600 of cannabis use disordered adolescents. And the University of Connecticut was one of the 4 sites. And now we have analyzed the depression. And mind you, the subject received only treatment for substance use disorder, but we wanted to see in the secondary analysis several years later what happened to their depression. So, so this is the study I told you about before, which is really interesting. And this is kind of the mechanisms how we are looking at this. But what we have found out in the CYT study, 3 findings. The first finding was that indeed 70% of the adolescents had at least one symptom of depression. Close to 20% met the DSM diagnosis for major depressive disorder. Depression predicted reduction in depression, but not reduction in substance use, and vice versa. Cannabis use predicted reduction in cannabis use, but not prediction in depression. So that's kind of interesting to know, and again, we're looking for more studies on co-occurring disorders. So to sum up, what makes it work? Proposed mechanisms are, some of our colleagues mentioned here, Dysfunctional reward processing might be a feature of comorbid depression and substance use disorder that is responsive to treatment. The second one, self-efficacy as a possible mediator between depression and substance use relapse. This is an old slide by Mars and Remo, but it explains pretty much what is the effect of depression, self-efficacy, and relapse. So I'll stop here, and thank you.
Thank you very much. I'm aware we have now more or less hit the time for our lunch break, but perhaps just the chance for a couple of questions before we go. If anybody's got some pressing questions to any of the speakers, could you raise your hand? Okay, then I'm going to let you go for lunch. So thank you very much once again to everybody that's presented. It's been really interesting. Thank you.